And you are going to be here at the session where we will talk about protecting people who migrate in countries of origin, transit, and destination. We will have about 90 minutes for this session, and we have some wonderful speakers. My name is Boris Dietrich. I work for Human Rights Watch, and I will be your moderator. We will have actually two panel discussions. One is focusing more on people in the countries of origin and emergence response, and the second part of the panel will be more about long-term responses. But first, I would like to introduce to you Jacqueline Bekers. She works for the IOM. And I would like to give you the floor. Maybe you want to sit here or stand over there. Thank you. Please go ahead.
Good afternoon, everybody. And first of all, we'd like to thank Boris for kind opening remarks. It's a great honor to, on behalf of the UN Migration Agency, address you all here at the session on protecting migrants throughout the migration process, along with distinguished colleagues and long-standing partners. First of all, I would like to emphasize some migration realities that we must come to terms with. We live in an era of unprecedented human mobility, a period in which more people are on the move than ever before. There are nearly 250 million international migrants and some 750 million internal migrants. Were all international migrants to live in one country, the population of migration land would be slightly less than Indonesia. The GDP of migration land in the form of remittances or money sent home of approximately 580 billion annually is roughly equivalent to the GDP of a small, medium-sized European country. Annual migrant remittances far exceed total foreign aid and are almost equal to all foreign direct investment. Money sent back by migrants is spent on health, education, and contributes to poverty alleviation and stabilization of communities at countries of origin. This makes migrants part of the solution and not part of the problem. IOM's vision is for a world in which migrants move as a matter of genuine choice and not desperate necessity, in which the rights of all migrants, regular and irregular, are protected throughout the migration cycle, and in which migration is well governed. So it is a positive force for all the world's peoples and societies. But the world we live in is in disarray. We witness an appalling lack of political courage and leadership, a serious erosion of international moral authority, and violation of international humanitarian law by all sides in conflicts. Unprecedented anti-migrant sentiments and xenophobia that manifest in anti-migrant policies and actions that perpetuate stereotypes, endanger migrants and deny countries the contributions of migrants. We are witnessing the greatest forced migration since World War II. Some 65 million persons have been forced to move. Over 20 million refugees across borders and some 42 million displaced internally within their own countries. Today, the most important challenge we face lies not in the numbers, though, but in the fact that policies have not kept pace with the realities and drivers of human mobility. The so-called migration crisis is one of policy, leadership and solidarity, not a migrant crisis. This increasingly visible crisis of solidarity calls for a new way of thinking about what development is about, including within the health sector. So why do we need to talk about the health of migrants and HIV and migration? Well, because the right to health is a human right and also applicable to migrants. Especially vulnerable migrant groups, women, children, undocumented workers, are at high risk of not seeing those rights realized. From a development perspective, migrants' health is a prerequisite for migrants to be able to contribute to development and enhance their personal well-being, as well as that of their families and countries of origin and destination. Moreover, from a public health perspective, addressing migrant health makes sense. It is cost-effective and improves public health outcomes. There is no public health without migrant health, as we always say. Most migrants are healthy and usually underutilized services, and migrants do not generally pose a health risk for hosting communities. Migrants should not be stigmatized or associated with the risk of importing diseases like HIV. While there is a clear relation between population mobility and the spread of HIV/AIDS, it is rather the conditions surrounding the migration process that can place people in situations of higher risk, and even more fundamental are the risks that may cause people to move in the first place. For example, people who are fleeing political instability, conflict, natural disasters are at heightened risk for contracting HIV due to the division of families and the breakdown of other social structures. Such risks may also be associated with the conditions migrants may encounter in transit, for example, in border areas, camps, holding centers, or when they arrive, for example, loneliness, exploitation, or long after they have settled in receiving countries. So while migration is a fact of life, large numbers of migrants around the world remain at high risk of social inclusion and exploitation, and tuberculosis and HIV are some of the major public health concerns disproportionately affecting migrants. Many lack equitable access to health services, and many are exposed to exploitation, poor living, working conditions, and occupational health hazards. Migrants may experience challenges in accessing HIV treatment and continuity of care in transit and upon arrival, either due to lack of entitlements to health services or other barriers to health service uptake, like language identification, cultural barriers. In many countries, the most important factor governing migrants' access to healthcare is their legal status and interest in controlling immigration. Additionally, discriminatory and stigmatizing practices that limit entry and stay on medical grounds persist. And in many cases, this implies the deportation of migrants affected by HIV or even pregnancy, for that matter. Lastly, cross-border mobility brings about disease surveillance and treatment challenges that makes understanding human mobility dynamics critical if we are to prevent and respond to disease spread in a transnational world. This is the time to underline the need for changed mindsets, new evidence and human rights approaches. The point is not about closing borders, excluding people from migrating or health system services, but it is about being inclusive and smart, innovative ways to address and finance the health of our increasingly diverse societies, for the sake of individual rights and well-being, but also for the sake of global health. Recent models of flexibility and innovation come from, by example, the Middle East, where a regional response has been supported by the Global Fund for TB, HIV, and malaria for countries hosting Syrian refugees. These should be evaluated as a means to reduce financial burden associated with care for migrants and for host communities, including national programs in migration-affected countries. We'll probably hear more from Peter Sands about that. The obvious answer lies in multi-sectoral and intersectoral partnerships and policies that enable migrants to be integrated into communities. After all, migration health raises questions of rights, social protection, public health, international relations, foreign policy, security and development, all at once. The health sector alone is not going to offer the solutions. So where do we go from here? What are our opportunities to promote the health of migrants? The Sustainable Development Goals and the 2030 Agenda, migration is no longer seen as a consequence of the lack of development, but migrants are seen as contributors to development. For example, while international migrants make up around 3.4% of global population, they contribute 9.3% of global GDP, according to McKinsey. Contrary to some populist rhetoric, migrants actually contribute more in taxes and social contributions than they receive in benefits. Migrants boost the size of the working age population, filling labor market shortages. Remittances dwarf all foreign aid, leading to improved development of home countries. The SDGs offer important entry points to uphold migrants' health through international responses that leave no one behind. Of course, universal health coverage, Goal 3, is only achievable if migrants' health is accounted for. Likewise, orderly and safe migration through well-managed migration policies, that's Goal 10, requires the mainstreaming of migrants' health in all phases of the migration process. On the migration and development side, well, on 19 September 2016, world leaders gathered at the UN in New York for the Summit on Refugees and Migrants, and IOM became a UN-related organization. The outcome of these deliberations was the New York Declaration, which spelled out agreed commitments. Amongst many other topics, the New York Declaration encourages states to address the vulnerabilities to HIV and the specific healthcare needs experienced by migrants and mobile populations. In addition, the declaration started an intense undertaking to develop a global compact for refugees and a global compact for safe, orderly and regular migration, or the GCM. The GCM draft was completed on Friday, 13th of July, just a few days ago, following a long member state-led process with the support of IOM, and will be considered for adoption in December this year at an intergovernmental conference on international migration in Morocco. This aspirational compact, albeit not binding, will provide a unifying framework of common principles, commitments and understandings among member states on all aspects of international migration, including humanitarian, development and human rights-related dimensions. This is going to be our migration government's architecture for years to come, and health must be there. IOM, WHO, HCR, UNAIDS, member states and other partners have worked hand in hand since the New York Declaration in 2016 to promote the integration of migrant health into these global compact processes. We are therefore most pleased that the final Global Compact on Migration draft includes health under several of its objectives. This is our opportunity to effectively link global migration processes with high-level global health processes and outputs, including the World Health Resolutions of 2008 and 2016 on promoting the health of refugees and migrants, the 2017 WHO Framework of Priorities and Guiding Principles on the health of migrants and refugees, the near-future Global Plan of Action of the WHO, the SDG agenda, of course, with targets on both health and migration, the NTB strategy, related Moscow Declaration, the UNAIDS strategy on the fast track ending the AIDS, in which migrants are identified as a priority population for targeted response. And not to forget UN efforts under the UHC 2030 partnership and the UN high-level meeting on TB at the UN General Assembly in September. That in fact affords an important opportunity to commit at highest level to not leave migrants behind and promote cross-border collaboration towards reducing TB and HIV burden. All the right elements and instruments are there. All these processes or political outlets exist and provide us with a rare opportunity to mainstream migration health as well as related partnerships in the HIV/AIDS agenda and promote the needed intersectoral partnership and policies that enable migrants to be integrated into communities. Let's make the most of it. But we must stop seeing migration as a problem to be solved and acknowledge it as a human reality to be managed. Thank you very much.
Thank you very much. Thank you very much, Jacqueline. So you are the Director of Migration Health Division at IOM. IOM is an intergovernmental organization.
It's a UN-related organization.
Yes, but my question to you is, we all know that there are countries and governments who try to close their borders, who are not focusing on the rights of migrants. So my question to you is, how does IOM deal with such governments? Is it very difficult, for instance, for you to contact ministers of health talking about health-related issues of migrants in those countries that are very difficult?
Of course, migration is a very, very difficult topic, and it's evidently not a surprise that the Global Compact on Migration negotiations were long and complex because it is difficult for member states to come to a consensus, but they did reach a consensus in this aspirational Global Compact on Migration. And it does set very important actions and commitments for governments to of course, try to adhere to, according, of course, bearing in mind the sovereignty of those countries. For IOM, I must say IOM has the big advantage of being a globally present agency. It has a very large footprint of national offices, which facilitates greatly the collaboration with governments within each country. And we usually have connections with ministries of health as well as interior labor and beyond. So it does facilitate our work a lot to be present in a country and understand the challenges that each country has. I think IOM, like migrants themselves, we connect countries, we connect sectors, we connect regions. And I think thanks to this very pragmatic approach and at the same time being very aware of country-specific challenges and policies, we are able to find solutions and most of all bring best practices, good practices maybe is a better word, and find solutions together with member states and partners. Because many of the complex policies, in our terms, complex policies, can be resolved if there is enough information, if there is enough knowledge, if there is enough evidence, and if partners around the table, all stakeholders, have a place to share their concerns. And this is, I think, a role that IRAM has been playing and can continue to play.
Fantastic. Thank you so much, Jacqueline. Let's give her a round of applause.
Thank you.
Please sit next to me. The next person I would love to introduce is Peter Sands. Peter is the Executive Director of the Global Fund to fight AIDS, tuberculosis and malaria. And yesterday we were also in a panel, and so I know that this is your first World AIDS Conference. Must be quite intimidating to realize that everywhere there are sessions going on at the same time. You always probably have the feeling that you are missing out on information because you're here and somewhere else, something else has been said.
I normally think I'm in the wrong session, actually.
But you know, we are discussing migration and global.
Really?
Yes, really. And the Global Fund has some programs in the Middle East, also in terms of emergency response. Maybe you could talk to us about those programs and the challenges you see for migrants who need to have access to HIV healthcare.
Absolutely. But let me start just building on Jacqueline's comments with a kind of high-level perspective of the nature of the problem. So we have some sort of 65 to 70 million forcibly displaced people, either refugees or internally displaced people. And these people are inherently particularly vulnerable to infectious diseases, whether it's AIDS, tuberculosis, malaria, or other infectious diseases. If you look at it from a TB perspective, it is hard to think of a better environment for turning latent TB to active TB and then creating infection around a community than a refugee camp. You've got stressed, immunocompromised people living in very close proximity to each other. This is, from the TB bacillus point of view, this is the perfect environment. And so these people are extremely vulnerable to infectious disease. They don't have access to normal, as they were, healthcare services, and they're often ending up in countries where the health system is already overstretched, even before you think of the incremental burden of having refugees or concentrations of displaced people. The other point, from a Global Fund perspective, we see this, and we see acute need, is they don't fit neatly into the Global Fund's classic allocation model. So our allocation model is around disease burden and GNI per capita, and that doesn't always take full account of rapidly changing situations around refugees or internal migration. Once we've done the allocation, the prioritization and the design of grants is done through a national-based CCM model, country coordinating mechanism, and particularly in environments where there is acute need within the country anyway, dealing with the issues of refugees isn't always the priority of the CCM. But fortunately, the Global Fund is actually a pretty flexible organization. And so through both our catalytic funding mechanisms and our emergency funding mechanisms, we have actually responded to displaced people situations. And you mentioned the Middle East, and I'll come back to that in more detail, but I think it's important to point out we are doing this with the Rohingya population, the refugees from Myanmar in Bangladesh. We're doing it with Burundian refugees in Rwanda. We're doing it in the whole Uganda-South Sudan situation. We're doing it with Afghan refugees, and we're doing it with migrants in border areas in a number of different countries. So, for example, Niger, Algeria. And these packages of interventions, sometimes we're dealing with all three of HIV, TB, and malaria. Sometimes we're dealing with a subset. It's TB-focused or malaria-focused, depending upon the particular situation. Now, in all of these, we are working with partners who, frankly, have deeper capabilities on emergency response and these sorts of refugee and migrant situations, and IOM is our delivery partner in a number of these situations, but we also work with UNHCR, UNDP, ICRC, UNICEF, and have set up kind of agreements and ways of working with all of them. And what we want to do is blend the capabilities and expertise organizations like yours have, Jacqueline, with our knowledge and experience of actually dealing with the particular infectious diseases. The Middle East one is quite an interesting example, because when we originally started, and this was a focus on Syrian refugees in Jordan and Lebanon, the initial focus was primarily on TB, and then it extended into HIV, and then we extended the geography from Jordan and Lebanon to include Syria, Palestine, Iraq, and Yemen. And it's become a reasonably big program. 17-18, it'll be $32 million, and the next phase of it is some $36 million. Another observation I would make is one thing we're very conscious of, particularly in countries where the domestic disease burden is high. It's also really important to think about how the programs in the recipient country are aligned, and that you don't create disconnects between what's being provided to the refugee populations and what's being provided. And so because there are, considerable issues and tensions, or potential tensions around sort of, are the funds being diverted, are they additional, all that kind of issue. I'm relatively new to this role. I began in the middle, in March. I look at this as something where this problem is going to get bigger, not smaller, and we need to think quite strategically about how we work with partners and how we think about the overall resource need here, because this is, as I say, the starting point is these are populations that are uniquely or particularly vulnerable to these sorts of diseases, and if we don't find solutions, and we have done so in a very sort of pragmatic way, but I think we need to think even more strategically about it. I mean, the one that's on the agenda with us as a live item right now is Venezuela, where you have effectively a collapse of the health system within the country, but you also have very large numbers of refugees crossing the border into Colombia and elsewhere, and the disease burden across all three of TB, malaria, and HIV is very significant. I'll stop there.
One question for you. Thank you very much, Peter. One question, you mentioned a few partners. How about the community itself, the community of migrants? Because, of course, they are in a very vulnerable situation, maybe not very well organized because they just moved and they are in transit. How does the Global Fund relate to the community itself and the needs they have?
I think that's a very good point, and I mean, I think a very candid answer would be that it works better in some places than it does in others. In some cases, you have external communities who are very good advocates for the people. In some cases, you have well-established community structures within the refugee populations. But in other cases, those sorts of organizations don't really exist. And particularly in the kind of fast-moving situations. So that is something that I would say we are probably doing a better job and our partners are probably doing a better job in some situations than they are in others.
Thank you, thank you. So let's move on to John Ryan. John is the Director General of the European Commission's Health and Consumer Protection Directorate. And to you, I would like to ask, John, a lot of undocumented migrants coming to Europe, and they are facing specific difficulties in accessing HRV treatment in Europe itself. Could you tell us more about the EU's efforts to address this situation?
Yes, good afternoon everybody, and thank you for the invitation. The first point I'd like to make is that migration has always existed. It's not a modern phenomenon, but I guess the size of the migrant arrival is something which is a new phenomenon, particularly in view of the security situation in other parts of the world. This is driving, when I'm talking about economic security and also real security, these drivers of migration are fueling fairly massive movements which are difficult to manage. The second point I wanted to make is that the profile of migrants varies over time. I was talking to a colleague this morning about the HIV profile of migrants in one member state, which for historical reasons coming from a particular part of the world is completely different to the HIV profile of migrants coming in through the Mediterranean. So I think there are variations in the situation across the member states, and depending on when the migration took place and where the migrants came from. The third point I'd like to make is that it's quite striking that when I attend the meetings of the Ministers of Health of the European Union, the 28 Ministers of Health, the only subject I can expect to hear on the agenda is not a health issue, it's a funding issue. They're all concerned about how to pay for their health systems. So the word which is on the agenda of every health council of ministers is the word sustainability. And this means that there is, in all of our member states, from the richest to the poorest, a pressure on resources and a pressure on money. There is not a magic money tree which you can shake and the money will come down. The ministers are forced to make choices between different spending policies, and of course the additional pressure which is put on, the stress which is put on our health systems in the European Union, even though we are a rich region, by the arrival of migrants is an additional factor. It's not as if the pot was a bottomless pot of resources. We have to make choices and reattribute money. So in this context, I think the European Union can bring value added in two areas. First of all, on the external aspect, and secondly, on the internal aspect. Now, on the external aspect, I think it's important to note that I mentioned the drivers of migration. The drivers of migration can be economic in nature, but they can also be in relation to peace and stability of regions. And the European Union is specialised, I would say, in reaching out to regions which are in conflict, and also reaching out to regions where there have been emergencies like natural catastrophes or war zones. And we do this through our emergency mechanisms and also through more long-term development aid. And this, of course, includes the health aspect, and also prevention of HIV and other communicable diseases is a major part of those investments. On the internal side now, if we look at the 28 member states and how the member states organise themselves, I've mentioned that they have been subject to a great deal of stress because of the sudden arrival of large numbers of migrants, particularly through the Mediterranean basin, resulting from situation of instability in the Middle East, but also economic instability in some African countries. And the major challenge for us is to see how we can process these new arrivals, how to integrate migrants, either if they stay in the member state of arrival, or indeed one of our big problems is that there is this movement of migrants from one member state to another. And we saw this very often, migrants being forced to go by foot or jumping rides on trains going from one part of Europe to another. I had the misfortune or the good fortune to meet a Syrian refugee in Luxembourg, where I live. I met him last week, and he told me that he had walked to Luxembourg from Syria. So if you consider that if I wanted to walk into the centre of Amsterdam, I'd probably be tired as a result. But he walked from Syria, and I think there's a great... you have to recognise the courage of people to make that movement, this human movement. We're talking about human beings who are not doing this for their own pleasure or for their own amusement. They're doing it because they were driven to do it. So I certainly recognise also that migrants have genuine expectations of quality of reception in the countries they arrive in, and we're doing everything we can to try and improve the quality of reception of migrants, not only from the health point of view, but also, I would stress, from the human point of view. In other words, making sure that people have a place to live, making sure that people have a school to go to, making sure that they have adequate resources to buy clothes and to eat food. So all of these aspects are important, and are also important for people's health. There's no point in having an excellent health system and providing good facilities for people on the health side if, on the other hand, their accommodation is very poor. So for me, it's a group of services, including social care, including education, including integration into the society, which will ensure that a person's health is dealt with in a holistic way. And I would say as well that we are working together with the WHO, the World Health Organization, the International Organization for Migration, in order to try and identify how we can concretely help the member states to improve the health care of migrants. I don't want to speak too long, but one or two examples maybe just to illustrate the concrete work we've been doing. The European Centre for Disease Prevention and Control is our CDC, the European CDC, and they have been very active in Italy and in Greece in particular, but also in Spain and Malta, in dealing with the arrival of new migrants on the European soil. In other words, how do you actually screen and deal with migrants when they get off the boat on the beaches in the countries of arrival? So it's a very disorganized process, but we've been doing our best to try and reinforce those member states of arrival by, for example, establishing a health record which people can bring with them as they move, for example, from Greece to Sweden, so that there is some trace of what has been done in the first country of arrival and what's happened on the different stages. Also reinforcing training for health professionals, for example, in the countries of arrival, and also reinforcing the teams of health professionals using European funds, where we've actually tried to reach out to Greece and to provide European funds for support in medical support in the arrival centres. The other issue, of course, is the long-term integration of migrants. So in other words, when they have arrived, when they've been screened, when they've found somewhere to live, when they have been, received into the society, how do you ensure their long-term integration and access to care? And I'd like to say just one word on HIV, since it's a HIV conference. I agree that this is the vulnerable groups aspect is something which really needs to be underlined. Migrants are vulnerable populations in the same way as the other vulnerable groups which are talked about in this conference. They're vulnerable groups because they may not have the same access to health systems. They may not have the same familiarity with the offer from the health systems. They may feel nervous. They may suffer from stigma, both internal and external. So all of these aspects are important, that we have to make a special effort, I think. And to give you the example of the Roma population, which we've been trying to deal with in some of our member states, we have developed what we call health mediators. So in other words, somebody to help with the mediation between the vulnerable population and the health systems. So all of these things, I think, are part of a continuum where we really need to reinforce our external support and reinforce our internal support for migrants in the long term in order to ensure a successful integration. Thank you very much.
Thank you very much, John. One question to you. When we read the newspapers, we read about discussions between EU member states in relation to the agreement of Dublin, the country of first entrance to the EU, and then people migrate to another country and then maybe sent back to the country where they started. In terms of this health record you mentioned, what kind of registration is there of, for instance, HIV? And I'm asking this because I know from other sessions that some of the people do not feel comfortable being registered because they actually don't really know what this government or the next government might do with that record. So how does the EU deal with that?
Well, I'm sorry that Dublin seems to have gained a bad reputation. I come from Dublin myself, and I don't like the fact that Dublin seems to be a dirty word for some people. But the idea of the arrangement in the European Union is that migrants should be registered in the country of arrival and not in the country where they finish up. So that's the Dublin principle, if you like, is the Dublin Treaty. And that means that if a migrant, for example, finishes up in Dublin, but that he entered the European Union in Greece, then Greece is supposed to be responsible for registering the migrant. And that's the legal situation. What you're saying is that what would happen to medically confidential information. Medically confidential information can be transmitted between member states and is guaranteed by European law. I think we have some of the strongest data protection law in the world. Those of you who have been looking at your emails over the last few weeks will probably have received many reminders from all the websites that you're subscribed to, asking you whether you agree to continue to receive emails from such and such a site. But this also extends to medical information. It's highly protected, and we would be very interested to know concrete examples of cases where, not where people are afraid, but where people's data has been shared without their knowledge or their agreement. And we will certainly follow up those cases.
Okay, good. Thank you so much. Let's move on to Marc Billot. He works for Médecins Sans Frontières, Belgium, Doctors Without Borders. And my question to you is, because you work especially also in African countries, in countries where there's a lot of emergency response needed, what are the main challenges for your organizations that you are facing, and how are you tackling those challenges?
Thank you, Mr. Chairman. Now, indeed, interestingly, I just also came back from last session about the reality faced by migrant population also in Europe. And unfortunately, indeed, challenges are seemingly everywhere the same. And this is not due to a regional difference. I think, like it was already said by the first speaker, migration is not a problem to be solved. It's a reality everywhere to be managed. And indeed, unfortunately, when we speak about migration, conditions are similar, usually because of the travel and detention conditions that these people face, the abuse that is linked to these moments of migration and movement. Which also brings that people then usually have limited access to healthcare, which leads to treatment interruption if they are on a chronic treatment or delayed start. Fear, I think, like you rightfully said as well, what is happening if I enter a clinic or a hospital, or I am registered as being HIV positive or TB patient, what will be happening with my data, with my information. And unfortunately, we see also now, I think in 2015, UNAIDS came up with with some statistics that 35 countries already in the world have signed up to prevent and to restrict access to their country for HIV positive people. So worrying situations indeed, because migration indeed is for the moment facing quite restrictive policies throughout the world. When we think about people going back home, forced returns, for example, usually also what we will see in Europe or in African countries is forced returns, where no consideration is made for their treatment, their ongoing treatments. And maybe we might have some ideas about how to solve this with an experience we did in South Africa. Interestingly still, I think basically many countries still do have somewhere a very open and encouraging laws towards migrations. I think about South Africa, where it is by law as well, the fact that no one can be refused treatment, and migrants and refugees have the same rights as citizens. And I think that's well seen. Unfortunately, now Europe is also giving a quite poor example through its restrictive laws, and is pushing also countries like South Africa to put aside their quite engaging and quite promising laws. And indeed, so that we see South Africa copying quite nicely the attitudes that European countries show towards migrants. And what we have seen in a deportation center close to Pretoria in South Africa is unfortunately a reality that we have also seen in Greek islands and elsewhere in Europe. Lack a complete abuse of human rights, lack of access that is adapted to their needs. I just recently also in the last presentation was referring to the absence of PEP, post-exposure prophylaxis, to people that had been abused sexually during their transit or even at the country of arrival. No access to condoms. Overcrowding. Overcrowding usually in these detaining centers also is a terrible situation we see. And that makes me thinking the overcrowding of both situation we've seen and we've tried to address in a Malawian prison. The central Malawi, or two central Malawian prisons, where we had up to 300% overcrowding. So they were 3 times higher than the prison was built for. And we saw by this not only a doubling of the HIV infection and prevalence, we saw, of course, also difficulties of the prison to cope for the malnutrition, for the water and sanitation. Imagine the latrines that are built for 100 people and you have 300 people. But on the other hand, also, we saw a dramatic increase of tuberculosis because of this overcrowding. Some data to consider. If in Malawi the incidence of TB is 190 new cases per 100,000, it was 15 to 18 times higher due to in the overcrowded prisons. We went to numbers up to around 3,000 new cases per 100,000 people. And interestingly, a risk analysis made with our statistics showed that there was a link between the overcrowding in a detention center and the tuberculosis infection, the new cases. So an inmate occupancy rate of 300% led to an 8-fold increase of incidence of TB in one prison. And if I speak about prisons, it's also because, well, of course, you have migrants in the prisons. If you have detention centers in South Africa or in Europe, they end up usually in a prison forgotten in other countries, and therefore it's even a further task for them to be recognized and to try to obtain the entry doors that might get them out of a prison situation. To end in a positive note, in Musina, it's a border town between South Africa and Zimbabwe, we've been addressing circular migration. Circular migration of farm workers coming from Mozambique or from Zimbabwe, where people came with the season to work in the different farms, northern South Africa. So this program started in 2010 and basically has now been taken over by the DOH, Department of Health, with 88 visiting points to the farms. It was not waiting for the farm workers to come, it was them, the DOH, to come and go to the farm workers, which of course are far away from the health centers. And basically the key elements of the strategic approach that we developed in there was fourfold, I would say. First, and it goes back to one of the information you'll get about data, give the power to the patient to own his own data. So it was a patient health card that he or she keeps. It's a health passport that can be used and that is recognized between the two countries, between Zimbabwe and South Africa. People can be acknowledging that they are on treatment and that they have been kept on treatment. Discuss with the people, if you are leaving, where are you wanting to go? Where are there places where you can access treatment. So let's take time, but this again takes time, takes support. Let's make a roadmap with these people and try to see what are the best addresses they can knock on doors for the security of their treatment. Many other examples we have been adapting, and for example also adapting the M&E systems, adapting the statistics, because that's also one of the issues healthcare workers usually miss, is about the fact, well, if he's going to leave after that, well, I have a defaulter in my statistics. That's rather annoying for my boss. And basically, well, that's what we tried also to develop. It's a temporary transfer out. This person's come back, or this person maybe not come back, but at least they've been highlighted as being of migration pattern. So all these little adaptations made that basically we made a kind of a pragmatic solution for a quite local problem between farm workers and basically their home country. But on the other hand, it assured afterwards as well, Department of Health of South Africa to take it up and to keep it sustained, and with the main objective, of course, to keep the treatment uninterrupted for the patients.
Thank you so much, Mark. Thanks a lot. Let's move on, because I also have to mind the time. So let's move on to Gary Jones. Gary, you work for UNAIDS in Kenya. Could you talk to us, because I think Kenya hosts one of the largest, maybe the largest refugee camps. Can you talk to us about migration and humanitarian settings and the problems you see there?
Yeah, no, certainly. Thank you very much. I think the first thing to say is that, of course, humanitarian settings, which can be defined in various ways, are often down to perception. You think it's clear-cut, but it rarely is. In its most basic form, it means when life and livelihood is threatened, and it means that drastic steps have to be taken in order to address those calamities. But sadly, as we've seen in Kenya and elsewhere, so much of those considerations are down to political opportunism as well as humanitarian principle. And I think this is one of the guiding features of migration. Migration and humanitarian settings are, of course, very closely linked. Humanitarian settings, such as we've seen in Kenya, northern Kenya, very often frame the start and the end of a migrant's journey, typically characterized by disruption of basic security, social health services, and systems of justice. Kenya provides a good example in which we see, for example, that humanitarian settings very much concern urban areas, urban conurbations now. The old idea of the rural refugee way away, far from settlements, etc., has long gone. In fact, this latest statistics are showing that most refugees, in fact, are urban refugees. So in some senses, we've got to reassess the paradigm that we work with. The informal health slum settlements inside the inner cities often exhibit the worst health outcomes of all, and very often they are the places of high HIV prevalence. And in these humanitarian urban spaces, these are very often the places where refugees, displaced people, that's where they reside and face multiple forms of ethnic and social vulnerabilities. These are the things that we need to concern ourselves with. We also have to realize as well that in times of crises, and the migrant's journey is so often, sadly, one of crises, codes of behavior, accepted codes of morality, moral behavior, they break down. And as people struggle to survive, to make ends meet, human rights are routinely violated with little respect for anything or anyone considered outside of the norm. And those sexual stereotypes often lead to discriminatory practices and destructive social and gender norms. In these settings, in these crises, it's very often easy to see that things diminish, including protection mechanisms, and sadly so often as well, the rule of law. When it comes, we need to talk a little bit about sexuality as well, because the narrative still to this day very often holds that in emergencies, as elsewhere, it's certainly the neoliberal, I think still dominant perspective, is that gender is binary. You're either a man or you're a woman. And very often we see this in the classic rapid response. For all good reasons, people want to get treatment out fine, so it's either men in this queue, women in this queue, for example. Well, we know now that's fundamentally wrong because, of course, gender is not and never has been binary, and it contains a host of different identities. But in failing to recognize that, as we've seen, in Kenya, we've come a long way in many ways, and in the Horn of Africa, but it's still predominant that when we run roughshod over those different identities, we can often then actually inadvertently heighten a sense of vulnerability and increase exposure to HIV. In humanitarian settings, we talk of the vulnerability, particularly in conflict, post-conflict, and in Kenya, of course, we have the situation in Somalia, in South Sudan as well. So these populations, they know about trauma, they know about crises, they know about the threat to life and livelihood. And we often talk about the vulnerability of mothers and of young women, of girls. And that's very true, but of course, young men and boys are equally vulnerable, and they're equally subject to cases of sexual exploitation and abuse. But again, given those sexual stereotypes, they're often not measured or unrecorded or simply hidden. But we know now from very good research, the evidence is showing across the sub-region that, of course, boys and girls, adolescent males, adolescent females alike, they suffer multiple forms of gender-based violence, regardless of their age, ability, status, sexual identity or orientation. I think we also need to look at as well is that when it comes to crises, and as I say, we look to stereotypes, behavior, codes of behavior, break down, people panic. It's all a case of survival. How are we going to get ahead? And that so often then it's a case of, how are we going to do this? How are we going to move forward? And falling back on a lot of coping mechanisms, they often have very negative connotations. We've seen a lot of early child or forced marriages. And that many of the populations in and around Kenya and the sub-region, we see that in those communities which practice, or we have the evidence for a high level of child marriage, they are also those communities, those settings that we consider humanitarian, that we consider fragile, and very often have the highest rates of HIV as well. So we have to be very much aware that when these coping mechanisms, they can actually also be very harmful, very destructive as well. But it's the element of choice as well that we often fail to see. I mean, it's very easy for us. We look at it, and we look at it with objective eyes, and we say, no, that's not right, that's not good. But then, when we actually put ourselves in the position of the beneficiary, I remember having a very telling, a very moving discussion with one man from Western Kenya, who'd lost everything in a flood. Very poor, very resource poor, and was now in a displaced camp. And he was telling me that he was happy because one of his daughters was going to be married now to one of the wealthier men in the area. She was going to be wife number 7 or 8 or something, I forget what it was. And I was taken aback, and I was sort of, well, how can you be so happy about that? Because this is a violation. And he said, well, what's the choice? What's the alternative? I can't feed her. She's going to sell sex. What's she going to do? That's going to increase her vulnerability. These are the sorts of gut-wrenching decisions that many people affected, they have to face on a daily basis. And I think that we've got to be very much aware that this is the reality of so many people, and sadly we're seeing this evidence as well amongst those migrant populations. But I want to conclude on a slightly more positive note. I don't want this all to be doom and gloom, because I also think as well, and I passionately believe this, that humanitarian settings can also be the means of very much a transformative agenda. We can address sexual harassment, gender inequality in these situations using HIV as the intersection, as the pathways, as the trailblazer, if you like, where we can then actually look at these incidents, these situations. We can actually then we can encourage and facilitate and promote more productive social and gender norms that taken together will help us to deal with cases of sexual and gender-based violence, as well as the culture of impunity that still surrounds so much of the discussion, the discourse on migrancy and HIV. Thank you.
Thank you so much, Gary. You described a real big problem, and the question I have for you is, how would you make that very concrete in order to have a rapid and creative response, keeping in mind all the problems you were talking about? Because in the beginning of your introduction, you talked about the lack of the rule of law, and people in such a setting, maybe not the best will come out of them because they are in a survival mode. So how would you create such a thorough and protective response?
That's a very good question, and of course there's no easy answer.
That's why I'm asking the question.
We can come up with an aspirational answer, but I think we can do much in our preparation, in our contingency planning, because as we've heard from the fellow speakers, a lot of this is cyclical, this movement, this migration. And I think as well we can identify the hotspots, the spaces of vulnerability, and that if we actually highlight them, then we can see, okay, well, we know this is very much a danger area for people or for whatever reason, so this is where we can actually concentrate. I think that's one of the things. And yes, we can advocate for the rule of law. We can have, there's some very good examples, if not necessarily from Africa, but I think from Latin America, where we've seen community policing, people on the move as well, where there's been champions, particularly trying to protect the right of the most vulnerable populations within their community. So I think that, yes, we can strengthen the rule of law, if not simply by thinking outside of the box and looking more to the community themselves to protect. Because as I say, I mean, look, codes of behavior break down, but that doesn't mean to say that all hell breaks loose. There is still cohesion. There is still an incredible resilience. I mean, look at the journey of the migrant, and I think the very fact that faced with so many hardships, they can still make good at the end of the day really speaks to the humanity of this question.
Thank you so much. Wonderful. Now, our last speaker is Dilshot Pulatov, who works in Tajikistan and also Kyrgyzstan. And you are also having a PowerPoint presentation, so we're very much looking forward to it. You work as a project manager for a few, and you specialize in labor migration, I believe, right? So please take the floor. The floor is yours.
Thank you. Good afternoon, ladies and gentlemen. On behalf of FU Network working on HIV sphere, harm reduction, and advocacy of gay population rights for health in Eastern Europe and Central Asia, I would like to present you a needs assessment of labor migration among people who use drugs in 2 countries. In the beginning of 2016, during FU Network strategy development meeting, it was decided to put on the agenda of our regional project on working with people who use drugs, collection of information about the level of labor-related migration experiences among people who use drugs. Taking into account general trends and similarities of labor migration processes in both countries, Kyrgyzstan and Tajikistan, survey task was to identify problems occur when people who use drugs plan labor migration, stay in labor migration, and return from labor migration. The methodology and the tools of FU survey were coordinated with the Committee of Biomedical Ethics of the Academy of Medical Sciences of Tajikistan. 600 people who use drugs, existing clients of harm reduction and HIV projects of 2 cities of Kyrgyzstan and 6 regions of Tajikistan were enrolled in individual face-to-face interviews. In accordance with its tasks, survey is confirmed that people who use drugs are part of general labor migration and engage in labor migration as a source of income. Both internal and external migration take place among people who use drugs. Amongst all 600 respondents, 27% of respondents reported that migrated in other cities within their native countries. And about 42% of people who use drugs reported already having migrated outside of their home country to earn an income. And 87% of respondents of this survey who are previously engaged in labor migration traveled to Russian Federation. Challenges. The analysis of response of 243 respondents who have experience of labor migration defines that during the period of labor migration, the main common problem faced by people who use drugs was lack or absence of information about organizations providing assistance to labor migrants in the recipient countries. It's 82%, and before departure from their home country, about 78%. Based on survey results, recommendation as follows: extending people using drugs access to information and resources for organizations working with people who use drugs in native and host countries, to establish informational sharing between partners, to provide social support to people who use drugs, labor migrants in native and host countries, and organizing system of legal information referral and legal support for people who use drugs who seeking assistance when their rights and freedoms are violated. Next step, FU network is developed the regional approach and in process of its launching. Objective is to improve PUD's access to information and services to ensure their health and rights security. And now, by using this opportunity, we are inviting interested parties to join new initiative of FU network in Eastern Europe and Central Asia, to join for cooperation and try to develop this new initiative of grassroots organization. Thank you for your information.
Thank you so much, Dilshad. Let me ask you, because to me it seems like a very difficult group. You talked about a survey, about 600, I believe you said, 600 people who use drugs. Do you have the idea that the people you could interview, that they are representing the whole group, or are there specific groups among the bigger group of people who use drugs?
This was not difficult to FU and our local partners, because we are delivering direct services for people who use drugs, and this service was conducted by individual face-to-face interview, and it means that each client who use drugs have an opportunity to provide their own opinion, and we avoid any situations when another opinion who are trying to represent the group opinion was included.
Okay. Well, thank you so much. I invite you to go back to your seat behind the table, because now, let me look at the time. Yeah, we have about 20 to 25 minutes for Q&A. So is there somebody who would like to ask a question? You see there are 2 microphones in the room, and I see already somebody jumping up and going to microphone number 4. So, sir, you have the floor. And please, maybe you can introduce yourself, maybe the organization you work for, and direct your question to one of the panelists.
My name is David Harry. I'm from the European AIDS Treatment Group in Brussels. I have a comment to make, because I'm running a global database on HIV-specific travel and residence restrictions since 20 years, and it's hivtravel.org. We have been a little bit quiet in the past years, but we made an update for this conference. Snapshot: countries with entry bars, 9 countries deporting people with HIV, 17. 12 countries have punitive laws affecting people for stays below 90 days. 48 countries restrict long-term stays beyond 90 days. laws and practices unclear in 24 countries, 143 countries without restrictions. hivtravel.org. This is published in collaboration with IAS.
Thank you so much. I see that behind you there's another gentleman standing. Maybe you would like to take the floor?
Thank you, Alisher Latipov, HIV Reform in Action Ukraine. But I work in Ukraine and originally I come from Tajikistan, so I have a question to Dilshod and, wanted also to comment maybe, to comment on the study and to maybe highlight a few areas of importance for us to pay attention. And of course, this issue of migrants, with countries of origin, transit and destination is a very huge one. And what Dilshod presented was that, we are dealing with a drug-dependent population on the one hand, and on the other hand, the destination country is Russian Federation. Yesterday we've heard that in Russia, ART is available only for the citizens of the Russian Federation, and there is a lack of resources both in terms of procurement of ART medications, but also in terms of human resources who could prescribe and ART and monitor. And when people cannot get ART at the country of destination, when they return, it often happens that they do not disclose to their families in the home countries about the virus. So I think when we deal with this kind of population, it's very important to also work with those who stay at home, the families, and to inform them about the migration and the potential risks their partners could face while in migration, so that they also know when the partners are coming back that there are certain issues that they could potentially discuss together and work together. Another issue is that we specifically talk about drug-dependent population, migrant population, and I guess I've done many interviews in Tajikistan and for baseline and for follow-up, and when we ask them, will you be available for a follow-up, they often, most of them say yes, because they are dependent on a substance, and with Tajikistan being close to Afghanistan and drugs readily available, not very many people would go for migration with their substance use dependency. So when they do go, because of economic or other reasons, we need to take into account that there is underlying substance dependency which puts them into increased risk of HIV, which also needs to be addressed in both transit and destination. This is just a comment and I guess a general reflection of the complexities we are dealing with.
Thank you so much. Dilshod, do you want to respond to the first part of the intervention?
We are now provide you with information which we get during this survey. And this is an opportunity to all interested parties to join us and together thinking about next step. Because as everybody knows that people who are using drugs is a very vulnerable group of K population, and this is first unique approach to deal with problems that facing during migration in host countries. Thank you.
Thank you. I see a gentleman here, microphone number 1.
Thank you. My name is Kweku Adamako. I'm the managing director of ABDGN, which is the African Black Diaspora Global Network on HIV. We've actually had observer status with IOM since 2010. I have a question, but first a comment or a reflection, I guess, that one of the principles I think behind the concept of leaving no one behind means we have to force ourselves to not continue to go for the lowest hanging fruit. And by that I mean the easy panel. It would have been beautiful to have an African migrant living in Amsterdam, of which I have met networks of African migrants in Amsterdam at this conference, was able to collaborate with a network of African women living with HIV based in the Netherlands to do a joint session in their networking zone. If a small grassroots civil society network in Toronto is able to make that connection because we force ourselves to climb that tree and not go for that low-hanging fruit because it's not there. And that's something I would hope that not only for the people who organize this session, but for yourselves when you're invited to do these things. And, you know, like Jacqueline, as having, you know, there are civil society networks who have observer status with IOM that you could easily say, can you come to me with this? Can you come with me to this session? And that's something, I guess that's my comment.
Well, let me respond. Thank you so much for this comment. And I know that this whole session will be recorded. So also your comment will be recorded. And I'm sure that the organizers and also participants to the panel and people in the audience will take note of this. Thank you.
Thank you. So my question is, I guess, to Jacqueline and Peter. We know that donor-driven priorities can be a catalyst for building civil society infrastructure. And your comment, Boris, earlier about this sort of the difficulties in building civil society networks within the migration sector. What do you think about migrants being identified as a key population? We know that in HIV, the framework of key pops has been a catalyst for funding, for building networks, and I think the idea was that those key populations, men who have sex with men, sex workers, prisoners, people who use drugs, that they would somehow pick up the issues of youth, of migrants, of women. And what we've seen, and you know, working in this network for 10 years, that hasn't happened. But could it happen if the Global Fund, if UNAIDS, if IOM came together and didn't go for that low-hanging fruit and said it's time to name migrants as a key population, which might be a catalyst for change? So curious to hear your thoughts on that. Thanks.
Thank you so much. I would like to ask Jacqueline and Peter to answer this question.
Thank you for these comments. They're very important. I first want to say one little thing about diaspora. And you're absolutely right, they're very important. And in fact, this is a very interesting group we have here talking about the health sector. The migration of healthcare workers, health workers, is a very interesting group of skilled workers who actually are very often untapped. That diaspora can bring fantastic bridging type solutions in countries of destinations where of course they may be practicing, but as well as the countries of origin, because they can bring a lot of knowledge to a country of origin. And there are some great examples actually next door. I have a very good a friend who actually is doing precisely that, and on top of that he is researching health of migrants, being a migrant, and teaching at the same time this country of origin on precisely this topic. It's a fantastic example. So well taken. And we have actually, as IRM, organized dedicated events to pay attention to the use of diaspora. Your other question on civil society, equally important, if not much more important. Evidently, we cannot work at all without the role of civil society and those who represent migrants, and in fact, migrants themselves. To be really frank with you, we talk about multi-sector approaches and so on and so on. To be really, really frank with you, looking at the biggest group of migrants, labor migrants, and issues like social protection and health, how do we reach or come to models of portable health, social protection and health insurances, and so on and so on. We have been working with so many partners on this, but very likely the solutions will come from the migrants themselves. Migrants should not be seen as powerless people. Of course, many are in very helpless situations. Very vulnerable migrants do not have a voice. But many millions of migrants are very strong and very innovative people. And they are the ones who found ways to transfer money, for instance, back to their home countries. We all know that, unfortunately, it's often a survival of the fittest situation. Very strong migrants actually reach their final goal. So yes, migrants should be part of the solution, as I said, and they're not part of the problem. And I'm very glad, actually, the Global Compact on Migrants that I mentioned pays a lot of attention to the role of civil society. And we have to indeed make sure that all stakeholders, including civil society, will be part of these dialogues and the implementation of the compact. Thank you.
Peter? And I see that we have many people behind the microphone, so I propose that people ask a short question, and maybe you can also answer a little bit quickly.
Short answers. Your first point, yes. Your second point, your second point on whether we should make migrants key pops. I definitely think we should work out some way of articulating the particular needs of migrants. Whether it's adding them as a key pop or finding some other framework, I'm not sure. But certainly as we go through our thinking for the next allocation cycle, this will be a topic that we will be discussing through the Global Fund sort of governance structures. What is the right way of thinking about? And there are subtleties to it because there are very different groups within the population. But I agree with you that it needs sort of clarity of identification.
Thank you. Microphone number 3.
Hi, my name is Anna Tucker. I'm a PhD student of University of Barcelona. I try to be short. First of all, thanks for a question about mobilization. I don't know if there are any migration-led NGOs, organizations here in this room. I'm not sure. Great one. So for me, that was a big surprise. I think it should be changed somehow. And we do not have really a strong voice of migrants. And I understand because they do not have citizenship and they do not vote. But there should be some platforms where they're able to voice their needs. And my actually question is about definitions, because we have so many definitions, and I'm really struggling with how they are used. We have mobile populations, we have trafficking, victims of trafficking, we have regular, irregular, circular, we have highly skilled, we have expats. And the thing is that people are labeled to one category in the country of the destination. And there are hardly one EU policy which acknowledge that migrants face multiple risks and they travel back and forth across migration paths and migration circle. So I think that would be nice if there are some efforts made to meet those complexity and to acknowledge the real situation of migrants. Thank you.
Thank you so much. John, do you like to respond to that?
Well, I don't think we have the time this afternoon to go into the intricacies of this, but just to say that there are legal definitions which are there. I don't think they're the solution necessarily to the problem, because migration is something which is actually a right within the European Union. But if you're a migrant coming from outside the European Union into the European Union, then there's a completely different legal framework which applies. So definitions are fine, but I think it really depends on the type of migration that you're talking about. I do want to come back to a point that was made earlier on, and I do recognise that in the European institutions, and particularly in public health, there is a democratic deficit, I would say, in relation to the voice of migrants. We have established a HIV civil society forum where we bring together all the NGOs dealing with HIV in Europe. And I'm sorry to say, and I'm regretting to have to admit, that we don't have a representation of migrants. And one of the things I will be taking home from this meeting is that we can issue an invitation to representative groups of migrants to join this civil society forum, because migrants are, whatever people might think, they are very deeply concerned by these issues of HIV, TB and hepatitis, and they should be there at the table, and their organisation should be there. So if there's one take-home message, this voiceless migrant population which we have at the moment, I think needs to be given a voice when we're developing new policies on HIV.
Perfect, thank you. We noted that. Microphone number 2.
Yes, thanks. I wanted to just to bring back a statistics that I have heard also during the conference that can be interesting. It is that because in Europe we speak often that about the fact that the new cases that are detected are from migrant origin, in Belgium, for example, from Central Africa and so on. But actually, more than 50% of these people, according to a study in 9 countries, has been infected when they were in Europe, so after they arrived, meaning that the vulnerability of those people, also, especially I think the informal ones or the illegal ones, before they get the wonderful complete package of Europe, they are the ones that are at risk, and so that should be brought into the discussion. And I have just a quick second question.
May I ask about your first question? To whom are you asking this? Who would you like to answer this question?
Well, it's more a comment, because I think we were speaking in Europe especially about the people who are in the system. We know the system can already make people ill also, like we know in mental health and so on. But also it is not from a public health point of view. I think it would be missing out a lot if we don't look at this group of people who do not have legal status and are not in the official system. No. That's general. And the second question is more asking the experts about that, how they see that the role of identifying vulnerable people and health problems within migrants coming into Europe, for example, how well can you combine that with another role, a role of security, of a role of deciding who will be able to go through the different procedures for asylum and so on. How healthy is it really to combine those two factors? Because we have some experience seeing that when people are coming in from the boat and from Italy and so on, victims of torture, for example, are not identified. Right? Only 1 in 3 are identified, which is a very vulnerable status. Is that because people are not trained, or is it because it comes into contradiction with certain instructions also, who can get that status?
Thank you so much. I propose to go to microphone number 4 and then to microphone number 1, and then we collect the last 3 questions. Oh, and somebody's jumping to microphone number 2, and I think that I give you the floor first, but only for a very short question.
Absolutely. So my name is Melania Trejo. I am a global health specialist and I work independently. And my question is for Peter Sands from the Global Fund. So since you mentioned Venezuela, I am from Latin America and I work a lot with Colombia, Peru, and other countries in the region. So talking about the Venezuelan diaspora, are there conversations about using Global Fund investment in the neighboring and migrant receiving countries, such as especially Colombia or Peru, to work with the Venezuelans?
Thank you. Now we go to microphone number 4. I mean, you have been waiting there for a long time. Yes. The floor is yours.
Hello, everyone. I am PC from Brazil. I'm an anthropologist and activist. And this discussion is very important, of course. And in Brazil, we are undergoing to another coup d'etat, and we are also losing our biggest health program in the world, SUS, and which is, well, it's okay. It attempts about 1,200 million people in Brazil, and we are paying Shell and Chevron oils with antiretroviral drugs by now. And because of that, there is a huge lack of medicine distribution. Already living many people are already living without medication and staying without medication for weeks. And this is happening as well as in Venezuela, and she said, and in consequence of global imperialism, especially because European and United States imperialism. I mean. And, well, democracy, you will know, is irrelevant to capitalism. And for that, in the sense, shouldn't we also discuss about racial capitalism and pharma and intellectual property and oil industries exploitations? Just what you think. Thank you.
Thank you so much. I see somebody standing behind you. Yes, ma'am, you have the floor.
Yes, my name is Anne Burton. I work with the UN Refugee Agency. Just a couple of comments.
Can you be very short?
Yeah,
Because we have to leave the room.
Will be very short. Just a couple of comments. One is I think it's important to get definitions right, because when we're talking about people on the move, refugees tend to move as families, and I think this actually gives them quite a few protective factors towards HIV, as opposed to labour migrants, and certainly as opposed to persons who have been trafficked. So I think it is important, rather than talking about migrants as a homogeneous group, the risks and vulnerabilities vary greatly, and I think we need to be actually very, very clear about which population of people on the move we are referring to. Secondly, to say that migrant populations have a higher HIV prevalence, and you're talking about migrants in general. Can I just, in terms of refugees, there have actually been a number of studies done, and generally refugees have lower HIV prevalence than the surrounding host community. There are certainly migrant populations, usually labour migrants, who in certain circumstances have been shown to have higher prevalence, but then these are the ones that we really need to be targeting. Lastly, just on the issue of key populations, migrants, not refugees, but migrants have actually been indicated as a key population in the latest UNAIDS strategy. But it does actually, it's recognised that it's very much it varies by context, and so once again it's important to look at the risks and vulnerabilities. Thank you.
Thank you so much. And then you have the floor, microphone number 1, for the last and maybe the best question.
Thank you. Hello, everyone. My name is Prakash Shakya. I'm from Nepal, and currently I'm working as a researcher in Tokyo, in Korean University, Tokyo. Basically, I'm working among Chinese, Vietnamese, and Nepalese migrants, their access to health services, including HIV testing services. What we have found in Japan is language barrier, difficulty in speaking Japanese, or with health professionals, or getting information, to access the health services. So language barrier has been one of the biggest problem for accessing the health services, including HIV testing services and other general services. So we are struggling in Japan on what kind of interventions, either maybe top-down or bottom-up interventions, we can do to deal with the problem to cross this language barrier and provide access to health services to migrants. So I would like to know from John, how in European Union they have tried to solve this problem of language barrier and provide health services. So yeah, that's my question. Thank you.
Thank you so much. Now, we don't have very much time, so let's be very quick with our answers, and maybe after we leave the room you can talk to one of the panelists if you would like that. So, Mark, do you want to start?
Yeah, no, sorry, just maybe on the last question, I think maybe, yeah, well, we can discuss further afterwards as well, but indeed it's one of the major issues. The healthcare workers don't speak the same language as the migrant and vice versa. And in that sense, where this happens, we work with cultural mediators. So people that indeed make that bridge and are translating for the migrant person. Very quickly as well on some other comments that have been said, I fully agree migrants and migration patterns are considered as a key risk factor and therefore they can be considered as key populations. What we speak about is undocumented migrants. So I remember just now as well the former presentation, the lady responsible in Amsterdam to decrease risks of HIV transmission, and she also said very clearly, yes, refugees, migrants are welcome and we serve them unless they have no papers, they are a problem and we don't have an answer on that. So I think it's really the undocumented migrant that is a problem in here. Very, very quickly then, as I have the word, yes, I think we need to think about the people staying behind. I fully agree, people that may come back or so on, because yes, that's also our experience in many countries. What happens with the spouse, for example, who stays behind? She might maybe be also at risk because how does she survive and how does she also, get money in? So she is first at risk because she doesn't have the breadwinner anymore. And when and if ever the person comes back, indeed, there is a problem there. And we've been thinking about strategies of providing these women with PrEP, pre-exposure prophylaxis, when they know if they can plan for the partner to come back. But many other answers, but unfortunately I will have to give the floor to others as well.
So in the last 1 or 2 minutes we have to wrap up, but there were some questions about specific countries like Brazil, Venezuela, Colombia. How does that play out? And there were also a few questions about who are we really talking about? Are we talking about labor migrants? Are we talking about refugees, other groups? So we should be very careful in defining who we are talking about. So who would like to respond to those questions? Yes.
Comment on it. To be very short, I think the status of a person and who we are really talking about, it's a very fluid situation. We shouldn't think of a type of migrant as that is that status and forever. One can be a documented, a legal migrant for many years, and from the next minute to the other, one becomes a so-called undocumented migrant. Person will still have documents, they just expired. That's the vast majority of the so-called irregular migrants. Don't see it as a static situation. It's a very administrative situation. What is your legal status? And that goes with your entitlements, including your access to health services and social benefits. So be very aware of that. But I do agree indeed, vulnerability is very closely linked to that status because that determines your access to health services very much, and of course the vulnerabilities that can go with it. Other thing is, there are no migrants in the room. I'm sure there are migrants in the room. Many of us are migrants. Don't see migration only as a very vulnerable group. Many of us are migrants, but I think what we want to talk about is those so-called irregular migrants.
Peter, do you want to talk about Colombia and Brazil?
Well, I'll talk specifically to the Venezuela situation, and just to say there's a lot of dialogue going on among different partners as to, in a sense, who does what. And both in terms of Venezuelans who have left Venezuela and are in the neighboring countries, and the situation in Venezuela. And those are sort of ongoing dialogue at the moment.
Thank you very much. I would like to thank the audience for you attending this session. I will be very, very brief by only saying that what really struck me and what I got out of this meeting is also that we shouldn't only talk about the needs of migrants, but we should also listen to them and their expertise. So migrants also have a vision, and that might help the organizations in developing a response that might be very fruitful. So thank you very much, and I hope to see you at other sessions. Thank you.